Hi, I'm Dr. Elizabeth Bradley, an oculoplastic surgeon at the Mayo Clinic, and I'm happy to be here with you today to talk about managing ophthalmic aspects of facial nerve palsy. I do not have any relevant financial relationships, and I will not be discussing off-label usage. I do have HIPAA authorization for full face photographs. Sources that I've used include those listed here. Our objectives are to describe the periocular and ocular manifestations of facial nerve palsy, to describe non-surgical and surgical treatment options for exposure keratopathy from facial nerve palsy, and to demonstrate surgical techniques for managing upper and lower eyelid malpositions from facial. We'll start with a case, that of a 62-year-old woman who is 5 days post resection of a cerebellopontine angle tumor in which intraoperative monitoring of cranial nerves 5 and 7 were performed. Cranial nerve 7 was intact at the end of surgery, and yet she awoke with this facial nerve weakness. But full recovery is expected. On postoperative day number 1, she had started some artificial tears. On postoperative day 3, ointment had been added, and her eye was feeling a bit irritated on day 5. So we saw her in the inpatient setting. She had this left peripheral facial nerve weakness, a widened palpebral fissure, a high tear lake, conjunctival injection, and decreased corneal sensation. So here she is trying to close. We can see that she has significant paralytic lag ophthalmos and a poor Bell's phenomenon. And she already had significant staining despite maximum lubrication. So she had failed maximum lubrication. She already has an epithelial defect 5 days into her facial nerve weakness. She has impaired corneal sensation, a poor Bell's phenomenon, but we're expecting that her facial nerve will recover. And so because recovery was expected, but she certainly needed an acute intervention, we decided that temporary tarsorrhaphy was the best option. So just to take a step back and consider the facial nerve anatomy, this is an intentionally busy slide showing how many functions the facial nerve does serve. So in addition to innervating all of the facial muscles, we can see in this schematic slide, it also has other sensory and motor functions. So also has sympathetic motor function to the lacrimal and salivary glands, causing salivary and lacrimal gland letdown, provides special sensory input, taste, and general sensory sensation to the patch of skin on the back of the ear. So those are the functions of the facial nerve. Facial nerve weakness can occur at any stage in life. It can be congenital, occurring in 1 in 1,000 live births, with trauma being the most common cause due to forceps delivery. 90% of those recover. But it can also be due to developmental injuries, including Mebius syndrome, which is rare, 6th and 7th nerve palsy, and that typically has no recovery. Acquired facial nerve weakness is common. Half of them are idiopathic without known cause. 20% are from trauma, with those being mostly due to surgery or to temporal bone fracture. 15% are tumor related, from most commonly acoustic neuroma or also from parotid gland mass. 10% are vascular in cause or microvascular, for example, diabetic facial nerve palsy. And then 5% have some other cause, such as infiltrative, inflammatory, or infection. Bell's palsy occurs in 20 individuals per 100,000 people per year, and pregnancy increases that risk threefold. The pathophysiology of Bell's palsy, it's felt to be due to HSV reactivation, and this is reflected with increased serum antibodies, and the HSV genome has been recovered in facial nerve endoneurial fluid. And then in some other cases, it's felt that just swelling from the infection, whether it be viral or otherwise, swelling in the parotid gland may cause some trauma to the facial nerve. We were interested in looking at the epidemiology of facial nerve palsy. HSV has been on the rise, and so we were interested to see if there was also an increase in facial nerve palsy. And using the Rochester Epidemiology Project here in our local county, we discovered that the incidence of facial nerve palsy has nearly doubled in the 2000s compared to the time period from 1968 to 1982. So when we think about those idiopathic facial nerve weaknesses or Bell's palsy, what are the classic findings of it? First, it is a mononeuropathy, so no other cranial nerves are involved, that typically progresses over 1 to 3 days. Patients often have a viral prodrome. They may have altered taste and a sensation of altered hearing. And patients can have either partial or complete peripheral facial nerve weakness. It's important in these patients to look for vesicles in the ear canal. That can be a tip-off that this is Ramsay-Hunt, which is a geniculate ganglionitis. This is from herpes zoster, manifest again as the vesicles in the ear, auditory canal, on the tongue and hard palate, causes a very severe and painful paralysis. And it's important to note this because only 20% of these patients will recover completely. So it has a poorer prognosis in general than a garden variety Bell's palsy. When should a patient with a facial nerve palsy be worked up? So imaging should be obtained, certainly if it's more than a single mononeuropathy, so if there's more than one cranial neuropathy, as in this patient who has a 6th nerve and a 7th nerve palsy, who on her MRI scan was found to have a pontine mass. Any slowly progressive facial nerve palsy where the progression extends beyond 3 weeks is concerning and needs to be imaged. And a facial nerve palsy that has not recovered by 4 months also warrants imaging. The issue often arises of when to do Lyme testing. Lyme is a known cause of facial nerve palsy. So if patients have had exposure in a Lyme endemic area to a tick during the spring through autumn season, and particularly if they present with bilateral facial nerve palsy or with other clinical manifestations of Lyme disease, whether that be a rash or systemic symptoms. And half of patients who have Lyme meningitis will develop facial nerve palsy. And the photos shown here are of a young man who was bitten by a Lyme carrying tick while out mowing his lawn. And he developed bilateral facial nerve palsy. So his face looks symmetric, but that's because both sides are affected, and you can see that on attempted lid closure, he has bilateral paralytic lag ophthalmos, and the facial expression that you see there, that was the extent of his facial expressions. He was unable to smile with either side of his face. So what is the appropriate treatment for an acute facial nerve weakness? We have good evidence supporting early treatment with prednisone and acyclovir based on a clinical trial and a meta-analysis. So corticosteroid treatment reduces the risk of unfavorable recovery by 38%. So all patients with Bell's palsy should receive a systemic corticosteroid, and antiviral treatment reduces the risk of an unfavorable recovery by 12%. And so the patients with a severe Bell's palsy should receive a systemic antiviral. I would say in practice, most patients who present to an emergency room with an idiopathic facial nerve palsy are being given both systemic steroids and antiviral treatment. So what are the chances of recovery from facial nerve weakness? It's very much age dependent. 70% overall can expect a full recovery, but among young adults, more than 90% will recover, whereas in those over 60, only 33%, so a third, will have a full recovery. 10% will have some minor weakness, and then 20% will have either continued significant weakness or synkinesis. So what are classic symptoms of facial nerve palsy? In addition to the cosmetic disfigurement from the weak face, patients have change in speech, difficulty eating, change in taste, drooling because of problems closing their lips, difficulty breathing because of alar collapse of half of their nose, eye pain because of the lid malposition and exposure, and paralytic lag ophthalmos, the blurred vision and tearing that go along with that, and tearing especially also because of loss of the lacrimal pump with the weakened orbicularis. So the things that we potentially can offer patients for managing facial nerve palsy are non-interventional, including increased lubrication, contact lens therapy, and then interventional tarsorrhaphy, either temporary or permanent, eyelid weights, either temporary or permanent, and lower eyelid surgery. And I'll go through each of these. So in terms of increased lubrication, patients often have a lot of questions about what lubrication to use, specifically what brand. I tell them that it really is like choosing a toothpaste, that they need to sample several and find what they like the most. That is a combination of viscosity and duration. Patient favorites tend to be the Genteel line, the Refresh line, and Sustain. When patients ask which strength or viscosity, I tell them whatever is the thickest drop or gel that doesn't blur their vision. And when patients ask if it should be preservative-free, I indicate that really most patients do fine with the preserved product, and it tends to be more convenient and less expensive. So it's the rare patient who requires preservative-free tears. I find that contact lenses can be very helpful for many patients with facial nerve palsy. First, there's the bandage contact lens. These are really ideal for a patient who has worn contact lenses in the past, even if it's been many years. I am comfortable leaving a bandage lens in for a week of full-time use if the patient is unable to remove the contact lens. In that case, I do give topical antibiotic prophylaxis because they're going to be sleeping in the lens, and I typically choose the 8.8 base curve. For patients where a bandage lens is not enough, then there's the scleral lens option. We use this primarily in patients who have chronic facial nerve palsy, and it's especially helpful for patients who have both absent corneal sensation and difficulty closure, so cranial nerve 5 and 7 combined. These are custom contact lenses that cost $600 or more, and I manage these with the help of the optometrists in our department. So with the scleral lens, of course, its footprint is on the sclera, and then the optic zone vaults over the cornea, and there's a space in between this precorneal fluid reservoir that bathes the cornea in tear solution during the entire wearing time. And we've really been able to rehabilitate some very unhealthy corneas using scleral contact lenses. For patients who need more help than is provided by lubrication and contact lens, we have the tarsorrhaphy option, which can be placed either as a temporary or as a permanent tarsorrhaphy. For temporary tarsorrhaphy, we have options of Botox into the levator muscle, where I typically use 20 units into the central part of the eyelid to paralyze the levator muscle for 3 months. Cyanoacrylate glue, which can be used to the eyelid margin, or my go-to, which is a suture tarsorrhaphy. And for that, I'm numbing the upper and the lower lids and placing a suture to the eyelid margin. It can be a foro suture, like a foro proline, and some type of a bolster, and I'll describe my specific surgical technique in an upcoming slide. And I've left in temporary tarsorrhaphies easily for 4 to 6 weeks and even for up to 3 months. Permanent tarsorrhaphy can be done with local anesthetic. Sometimes patients require sedation. And in this, the eyelid margin is divided along the gray line. It's de-epithelialized along the anterior and posterior lamella, and then I do a 2-layered closure, often with a chromic suture. Most permanent tarsorrhaphies can ultimately be divided with reasonable cosmesis. I rarely use this as a primary means of treating lag ophthalmos. There are so many other techniques that we can use to help with eyelid closure that don't limit the peripheral vision and don't give the cosmetic disfigurement of a permanent tarsorrhaphy. So here is my temporary tarsorrhaphy technique. Again, local anesthetic into the upper and lower lids. I'm using a foroproline and then some type of a bolster. In this case, it was a sponge insert that comes in a 6/0 silk suture package. A red rubber catheter also works very nicely. And then I'm placing a mattress suture through the bolster with a goal of giving about 30 to 50% closure so that we can still examine the cornea but provide excellent protection for the eye. And then just another example of a temporary tarsorrhaphy using the red rubber catheter. Eyelid weights can be placed either as a temporary external non-surgical weight or permanently within the eyelid. The external weight is manufactured by MedDev. They're Blink Ease weights. These are flesh colored. They come in 5 different flesh tones. The patient applies it daily with a double-sided adhesive strip The physician writes the prescription, which the patient orders online. The cost is very reasonable, less than $200. And I have found that these can be most useful in a highly motivated patient who has a temporary facial nerve palsy. So I've particularly used these in some patients who've had complications from surgery, say with another surgeon, where they have a temporary weakness to the facial nerve, but that we really expect to recover. We don't want to do surgery, but we want to give them some protection and allow them to maybe back off slightly on the artificial tears that they use. So these can be very useful in that group of patients. We can also implant an eyelid weight, of course, as either a gold or platinum internal eyelid weight. I am always careful to explain to patients that this is going to give passive but not active closure, so it can help with the blink and with kind of a slow closure, but not the tight closure that the orbicularis muscle is able to provide. It also does not help with nocturnal lag ophthalmos, and in fact actually may tether the eyelid open, especially in somebody who is a back sleeper, who has that weight placed in the lid and it's really propping the eyelid open during sleep. I select the weight in clinic by taping it onto the pretarsal surface, and surgically the weight can be placed in either a pretarsal or a supratarsal location, and I'll discuss that more in upcoming slides. The weight can be made either of gold or of platinum, and the platinum weights in particular come as a solid versus a chain. The platinum is more dense than gold and so is a slightly lower profile, placed in a pretarsal location. When I'm placing it at a supratarsal location, I don't see really any advantage to the platinum weight, and the platinum weight is significantly more expensive than the gold weight. These photos demonstrate pretarsal versus supratarsal placement. So on the left panel of slides, upper and lower lids show a pretarsal placement that this patient had this weight placed elsewhere. It functioned well. You can see she has excellent closure of the lid, but it is visible and it's starting to extrude. It's now hanging down below the eyelid margin and is visible in the pretarsal skin. And so we removed the gold weight and instead replaced it with a weight that was slightly heavier, that was placed in a supratarsal position. So up above the tarsal plate, you can see that it is no longer visible in that pretarsal space, either with the eyelids open or with the eyelids closed, and is giving adequate closure. It does not give as full closure as the pretarsal weight because the vector is different. It's sitting up higher and has to go over the round globe, and so does not give quite as good of closure, but in this patient gave adequate closure with excellent cosmesis. This shows the technique for placing the weight. So the inferior edge of the weight is placed at the superior tarsal border. It can be placed either anterior or posterior to the levator aponeurosis. I tend to place it posterior to the levator aponeurosis, and then I can adjust the eyelid position by adjusting the levator. And I increase the weight by 40% compared to what I measure in clinic in the pretarsal location. So if I place a 1 gram weight in clinic and that gives good closure, then I'm typically placing a 1.4 gram weight in a supratarsal location. And as I stated earlier, I really don't see an advantage to a platinum weight when placed in the supratarsal position. So here we have some intraoperative slides. We can see the forceps are grasping the levator aponeurosis, which you can see transitioning to the levator muscle. And here the forceps is showing the Mueller's muscle with the arcade running through it. And so we are going to be placing the weight right anterior to that levator, sorry, anterior to the Mueller's muscle and inferior to the levator edge. So here it is sutured into place with its inferior aspect at the superior tarsal border. And then that does allow me to bring the levator aponeurosis anterior to the weight. And again, I can adjust the height of the eyelid position based on how tightly I suture the levator aponeurosis. And here we are closing the auricularis over top of the weight. And we can see a before versus after supratarsal gold weight placement on attempted closure. So before on the left hand, you can see that there's about 4 or 5 millimeters of lag ophthalmos, and after on the right hand part of the slide, improved closure, we're down to having just about 2 millimeters of lag ophthalmos. And this is that same patient showing that the gold weight can be done in conjunction with other facial nerve procedures. So this patient also underwent external direct brow lift bilaterally and blepharoplasty, and then a labe flap, bringing the temporalis muscle down to recreate the nasolabial fold and a smile. And then finally, we can adjust the position of the lower eyelid to try to reduce the lag ophthalmos that we see in facial nerve palsy patients. The patients with facial nerve palsy really can have several abnormalities of their lower eyelid. They can have eyelid retraction. We see this when there's really not any laxity and the lid descends inferiorly, so we're seeing this mostly in young patients. We can see frank ectropion that occurs when there is eyelid laxity, either medial or lateral, and the lid everts. We can also see steatoblephron, where the fat migrates forward because it's not held in place by the orbicularis muscle. And in patients who have synkinesis, we can see abnormal eyelid position and movement based on that. The series of photos just shows age-related changes in the lower lid position. So in these patients all with congenital facial nerve palsy, you can see that there's a widening of the fissure with a slight lowering of the lower eyelid compared to the contralateral side, but no frank ectropion. And then as we get into the 20s, 30s, even early 40s, the lower eyelid retraction becomes more noticeable. And then in the 50s, you get lower lid retraction, and then you're starting to see more laxity where the lower lid is tipping away from the eye. So you're starting to see the beginnings of ectropion typically in this age group. And then in the 70s and 80s, you typically see more severe frank ectropion of the eyelid. So what are indications for intervening with the lower eyelid? Certainly if we have ocular exposure, tearing symptoms can be related to lower eyelid malposition, blurred vision from looking through the tear lake or from ocular exposure, and poor symmetry and cosmesis And then sometimes we need the lower lid to be better positioned to help with contact lens fit. Our options for managing the lower lid are several. We can recess the lower eyelid retractors, we can place a spacer graft in the lower lid, create a lower eyelid sling, do a canthopexy or tarsal strip, and then suspend the mid-face. So we'll look at each of these. The lower lid retractor recession, that gives about 1 to 2 millimeters of vertical elevation. We see that same patient whose pretarsal weight we had repositioned. We also were looking at her lower eyelid being out of position by about 2 millimeters. So for the lower lid retractor recession, I'm using a transconjunctival approach with a hot temp cautery where I recess the retractors into the fornix. That gives the option of placing a spacer graft into that space versus just re-advancing the conjunctiva and closing directly. And a mid-facelift can also be added through that posterior approach. And for adults, I'm typically closing with a frost suture for 5 to 7 days to really give lower lid support as it heals. And I will have a video showing the technique. Here are some still slides. First of all, making that conjunctival incision. Then using the hot temp cautery. So here I've incised the conjunctiva and the lower lid retractors. They're very intimately associated in the lower eyelid, and so in recessing the conjunctiva, the lower lid retractors easily come with it. So the forceps is holding conjunctiva and lower lid retractors together. And then the lower lid retractors can be dissected off of the conjunctiva, which is then advanced and secured back to the inferior cut edge of the tarsus. And so with that, then again, showing this patient preoperatively on the left and postoperatively on the right, we can see that she has had an elevation in that lower eyelid position by the 1 to 2 millimeters that we predicted just with that very simple technique. So when am I adding a spacer graft? I find that to be helpful in an atrophic lid, such as is shown here. It gives 2 to 3 millimeters of vertical elevation. The technique is still that transconjunctival approach, recessing the lower eyelid retractors just as I did previously, but in this case into that posterior lamellar space I'm adding hard palate or alloderm and then closing the conjunctiva. With a plain gut. And so here shows just how we approach the hard palate harvest. Can make a template of some type. It's usually about 8 to 10 millimeters across by the width of the eyelid, so about 22 to 25 millimeters in length. Here's that posterior lamellar dissection showing the bed that palate graft is going to go into. And then just before and after again with the paralytic lag ophthalmos. So this gentleman had that very atrophic lid, significant paralytic lag ophthalmos with about 7 or 8 millimeters of lag ophthalmos versus postoperatively his lid is in much better position and he has reduced lag ophthalmos to about 3 millimeters. We've also implemented a technique, a palmaris longus tendon sling. That's really giving us the most vertical lift, more than 3 millimeters of vertical lift. And I will illustrate this in a surgical video, but essentially we're making a gull wing incision at the medial canthus, a pretarsal tunnel, passing a drill hole in the lateral rim, and then taking a tendon that is the palmaris longus tendon from the wrist, a portion of that tendon, although suture can be used as well, but the tendon really is the perfect tensile strength, stringing it through that lateral rim drill hole into the pretarsal space and then around that medial canthal tendon to give us an excellent elevation of the lid. And so here's just showing that we're just taking a split thickness palmaris longus tendon that's about 8 centimeters in length. And then we've made the gull wing incision medially, and then laterally we've accessed the lateral orbital rim through a lateral canthotomy. And then in this case, this was being done in conjunction with upper eyelid surgery as well, a gold weight placement. And this video will show the surgical technique. The first portion of it will show the recession of the lower lid retractors, and then we'll show the placement of the sling with the gull wing incision, and then making the pocket for the sling in the pretarsal space and exiting laterally. And these full face photos show a patient who has undergone the retractor recession and that tendon sling in conjunction with strabismus surgery done by a colleague, as well as facial reanimation surgery. And so she really has had excellent rehabilitation of her facial movement. So she's got much more dynamic movement as well as static position of the upper and lower eyelids. So for paralytic ectropy, and even though that's a more severe lower eyelid malposition, in many ways it's easier to fix than lower lid retraction. The lateral canthopexy lateral tarsal strip procedure is usually sufficient in these patients. And then if needed, you can add tarsal rotational sutures or reverse quicker type of suture using a 5-0 chromic. And again, this just shows pre and post with a very simple lateral tarsal strip and canthopexy, performed also in conjunction with some eyebrow and blepharoplasty surgery in lower face surgery. And so here's full face photo before and after the brow ptosis repair, blepharoplasty, gold or platinum weight insertion, lateral canthopexy, and temporalis transfer. So what are some of the limitations of lateral canthopexy and tarsorrhaphy? So the lateral canthopexy, again, it's useful for ectropion, but it does not vertically elevate a retracted lower lid. And then the lateral tarsorrhaphy limitations are that it affects the peripheral vision and has poor cosmesis. So really we're finding that the hard palate graft and then especially the tendon sling is better for eyelid retraction than either the canthopexy or the lateral tarsorrhaphy. Just a few slides on synkinesis. So these are patients who have return of facial nerve function in terms of strength, but with miswiring of the facial nerve, so that they have synkinesis, either when they try to smile, their lid closes, or when they blink, their lower face moves. In these patients, the lower eyelid can be in an elevated position due to increased orbicularis tone. It can affect the reading vision. Typically, this is quite easily managed with Botox, about 5 to 10 units into that lower eyelid. And you also could consider orbicularis myectomy or neurectomy of the facial nerve, or neurotomy. And then another entity that I've been noticing in patients with facial nerve weakness is that they get this fat prolapse due to orbicularis weakness, where their orbicularis is allowing the fat to prolapse forward, and they're tending to have unilateral steatoblepharon. So this patient came in and she was quite bothered. She'd had overall good recovery, but with some synkinesis, but she was really bothered by the steatoblepharon of her right lower lid, whereas her left lower lid had less severe aging changes. And so she underwent unilateral lower eyelid blepharoplasty. This was a situation where instead of just redraping the fat, I actually resected fat because there wasn't really anything to hold that fat back. And she was very pleased with the improvement in the symmetry. I'd like to say a few words about our facial nerve clinic. Most of the patients who I've shown here have been taken care of by our multidisciplinary team. So our team members are Samir Mardini, who's the plastic surgeon leading the team, and I'm there from ophthalmology. Dr. Beth Robertson is our neurologist, and my colleague Muriel Shornack is our optometrist, who helps with many of the surface issues of these patients and contact lens fitting. And then we also have 3 physical therapists who work with us and a clinic coordinator. And our facial nerve team really embraces the Mayo core value that the needs of the patient come first, and that really in order to advance knowledge and heal the sick, that we need to join forces and work collaboratively. We see the full range of patients with facial nerve disorders in our facial reanimation clinic. We see young patients, old patients, patients with facial nerve weakness, patients with synkinesis, patients with anesthetic corneas from cranial nerve 5 and 7 combined. And so we really are interested in helping patients with all disorders of the facial nerve. Our clinic meets every other Wednesday. We see 4 new patients with facial nerve disorders. That's a full clinic load for our neurologists. We're also seeing follow-up patients of our own in addition to those 4 new patients. Then we meet as a team over the noon hour, and then Dr. Mardini, the plastic surgeon, and I hold OR time later that week for our patients who come from out of town who need urgent intervention. Patients have a busy schedule. They meet in the morning with plastic surgery, neurology, ophthalmology, and they obtain standardized photos and a video. And then in the afternoon, they come and have the summary recommendation from the team. They go to physical therapy, and depending on their needs, whether they have synkinesis or weakness or ocular exposure, they may have Botox or see Dr. Shornack for contact lens placement or undergo facial nerve testing with EMG. Our goals in establishing the clinic were to provide integrated multidisciplinary care that would be more convenient for patients, to provide expertise in each aspect of facial nerve palsy diagnosis and management, whether it be the eye or the face, and to challenge each other really to do our very best work, and in so doing ultimately to improve treatment outcomes both for individual patients and collectively. This patient was one of our very early successes. So he was a young gentleman who'd had a tumor resected and had a facial nerve palsy. He'd had a gold weight placed in a pretarsal location that was reasonably good in function, but poor in cosmesis, and he had an absent smile and a retracted right lower eyelid. And so he underwent gracilis muscle flap to bring fresh muscle into the side of his face. That was innervated with cross-face nerve grafts, as well as what's called a babysitter procedure, when the ipsilateral cranial nerve 5 is hooked up to the muscles of that right side of the face to provide tone. And then he underwent replacement of the pretarsal weight with a supratarsal weight, and we recessed his lower eyelid retractors and performed the palmaris longus tendon sling. And then this patient who I showed earlier, he had undergone the brow ptosis repair, blepharoplasty, supratarsal weight, lower lid canthopexy, and a Labé procedure for his smile. He was the one who told us that, you know, you're never too old to want to smile. So we do surgery on patients well into their 80s or even 90s. Just a few words on synkinesis after facial nerve palsy. So as we discussed before, 10% of patients recovering from Bell's palsy will develop synkinesis. There's oral ocular synkinesis, which is lid closure that happens with lip movement. And there's oculo-oral, which is a facial twitch that happens with blink, and patients are often unaware of that. Patients can also get platysma, contraction in the neck, with synkinesis, and crocodile tears, which is gustatory lacrimation. That's a form of synkinesis. The mainstay of synkinesis treatment is Botox. Other botulinum toxin options are available, both botulinum toxin A and, as I'll discuss on the next slide, botulinum toxin B. So Botox is a botulinum toxin A option. I've used the other botulinum toxins for other situations, but I've exclusively used Botox for synkinesis. It's FDA approved for a variety of indications, including hemifacial spasm and facial spasms, which are how we code synkinesis. So yes, that's by far and away the most common toxin used for this. Xeomin is FDA approved for blepharospasm, cervical dystonia, and glabellar folds. Gets dosed the same as Botox. Dysport is FDA approved for glabellar folds and gets different dosage compared to Botox. And then MyoBlock, which is botulinum toxin B, is FDA approved for cervical dystonia. It's generally more painful than botulinum toxin A. And because our synkinesis patients rarely lose Botox efficacy, again, I'm just simply not using MyoBlock or the other botulinum toxin A's for this group of patients. I do use them sometimes for blepharospasm patients. I reconstitute my Botox typically at 5 units per 0.1 cc using buffered non-preserved saline. It's important to tell whoever's mixing it that it really needs to be mixed very gently. It's susceptible to degrading with non-gentle handling, and it needs to be used within 4 hours. For the synkinesis patients, start at a very low dose compared to what you might be used to with blepharospasm or hemifacial spasm patients, because these patients often have some underlying weakness and they're highly sensitive to going back to being too weak. Topical anesthetic is optional. Most patients do fine without it, and I typically use a 30 or 32 gauge half-inch needle. In the upper eyelid, you can paralyze the orbital orbicularis if the patient has brow ptosis. That allows the brow to go into a more elevated position. Typically, I'm using it in the pretarsal location, avoiding the middle of the lid, and I use about 1 to 2.5 units medially and 1 to 2.5 units temporally in that pretarsal space as a starting dose. And then the lower lid, I'm giving a temporal single site injection, usually 5 units to start in these patients. So very, very low doses of no more than 10 to 12 units in the periocular region for the single. For patients who do have crocodile tears, Botox into the lacrimal gland can be highly effective. I take a transconjunctival approach, injecting 2.5 to 5 units. About half of patients will respond to that 2.5 unit dose. About 80% will respond to a 5-unit dose. But the higher the dose, the more likely you are to give a temporary ptosis. That occurs in about 10% of patients or so who have the 5-unit dose. Botulinum treatment for synkinesis is illustrated by this case, a 70-year-old golfer who had developed Bell's palsy 5 years previously, and he noticed that the left eye would close when he would make a particular facial expression while putting. And so we treated his pretarsal area with Botox nasally 2.5 units and temporally 2.5 units, and then some Botox into the lower eyelid, and he really had good response, as you can see in the top panel, which is pre-treatment, versus the bottom panel, which is post-treatment. If you look at that middle panel especially, you can see before treatment when he would make that grimacing expression that the lid would close most of the way, and then post-Botox he was able to keep the lid open to clear the pupillary axis when he made that same expression. So nearly all patients will have a response when treated with synkinesis, when treated for synkinesis with Botox. The onset is around 3 days, and it's maximal at 2 weeks, and lasts typically for 3 to 6 months in these patients. So the side effect that's most common is ptosis, about a 10% risk, again, when we're injecting into the lacrimal gland, much lower when we're in that pretarsal space, but still not zero. Aproclonidine can be used to treat the ptotic lid if it's bothersome, and we reassure patients that that ptosis will resolve in about 6 weeks. Another side effect, not a complication, but a known side effect, anticipated side effect, is that paralytic lag ophthalmos is going to ensue. It's that balancing act between being able to treat the tight muscle, but allowing still some function. And so patients may need to resume some nocturnal lubrication. So this is a patient shown with reasonable closure, but still somewhat impaired pre-Botox on the left, and then after Botox, she's had a recurrence of lag ophthalmos. So to summarize, management of the periocular aspects of facial nerve palsy. If the facial nerve paresis is mild and temporary, then ocular lubrication and/or a bandage contact lens often suffice. In the setting of cranial nerve 5 impairment, aggressive protection of the eye is needed. Supratarsal placement of the eyelid weight can offer better cosmesis than pretarsal weight while still maintaining adequate closure. And for the lower eyelid, age is a major determinant of lower eyelid findings and facial nerve palsy. The lateral canthopexy is appropriate for ectropion, but for eyelid retraction, more sophisticated procedures like a tendon sling or a spacer graft are typically required to treat the eyelid retraction. And with that, I will be happy to take any questions during the question and answer session. Thank you.